Hello, my name is Ravi. I'm from My Cancer Haven, and today we have one of the leading authorities in acute leukemia in the country with us today. We're really privileged to have him, Dr. Harry Erba. He's professor of medicine, director of the leukemia program at Duke Cancer Institute, but that just doesn't cover it all. He's chair of numerous committees, including the SWA Cooperative Group Committee that decides on clinical trials in this disease in the United States. So we're really blessed to have him. And we're going to talk today about AML, a provocative title, Farewell to Intensive Therapy. Welcome, Harry.
Hi, good to see you again, Ravi.
So, Harry, just to put it in perspective for our audience, give us the background. Where have we been and where is this trial trying to take us?
Well, I'm going to start, Ravi, by saying I'm really glad that the title slide here had a question mark after farewell to intensive chemotherapy.
Sure.
I've been doing this for 30 years, and much of my career has been to developing less intensive therapies, and to find myself in a position to say, well, maybe not so fast to get rid of intensive chemo is a little weird. But you know how these things ebb and flow in medicine. But where we've been since 1973, when Yates first published the landmark article on cytarabine for 7 days and 3 days of an anthracycline, in that case daunorubicin, is that has been our standard of care for fit patients with AML. And we know that this is a tough regimen to go through, even for younger patients. There's a 5% early mortality, typically related to mucositis and infectious complications. And despite many years of trying to improve on the outcomes with that intensive chemotherapy by adding other chemo drugs or changing the sequence, nothing has ever been shown to actually improve on the outcome of our patients with AML in a randomized trial, with the exception of the addition of midostaurin or quizartinib in FLT3 mutated AML. And there is, I think, sufficient data to show that the addition of gemtuzumab ozogamicin could be very helpful for improving survival of patients with AML that have an 821 or inversion 16, the so-called favorable risk diseases. But otherwise, I agree with what's listed here, that the plateau that we've reached a plateau. And recent data has shown even in patients with more favorable risk disease, the overall survival at 5 years is only 50%. And for adverse risk, it's around 10%. So we clearly have a lot of work to do. Now, what has been a blessing really yeah.
Go ahead.
Should I go on?
Yes, please do.
Okay. Can you go back 1 second? I just want to set the stage.
Definitely.
Sorry. I know I'll try not to take too much time. Okay. What's been a blessing for the patient population with AML is really the development of the regimen of the BCL2 inhibitor venetoclax with hypomethylating agents or low-dose cytarabine. So typically azacitidine is used because it was shown to improve survival, and it was a regimen that older patients can tolerate with low induction mortality. In the phase 3 study, it was less than 5%. And importantly, the survival was improved even in the patients who were 75 years of age and older. When you consider the median age of AML to be 68 to 70, this is a significant population. And then we now have a regimen that improves their outcomes. And what's interesting is that the benefit was seen in many subtypes of AML that typically do not respond very well to intensive chemotherapy. Not all, but definitely some. And so based on the fact that the intensity of the treatment was less, and yet there was efficacy, many of us have been wondering for years if we should be moving a less intensive regimen like azacitidine and venetoclax to younger patients, especially younger patients who might be fit for intensive chemo, but we know the biology of the disease is such that they're unlikely to have a long-term benefit. And that was the genesis of the paradigm study shown on the next slide.
So go ahead, tell us about what was the study design.
So, what's incredible about this, I'll just say, Ravi, is from a social aspect, clinical investigation. This was a study that was started by our friend Amir Fati at the MGH. He got 9 major academic centers on both sides of the country together to do this study. It was an investigator-initiated trial, no outside funding, and he got this done to try to answer at least a very important question. And this was a plenary session presentation at ASH 2025. So what they did in this study is they said, okay, we're going to treat AML patients, adult AML patients, regardless of their fitness for intensive chemotherapy, which is really hard to actually quantify or determine. And we're going to randomly assign them to conventional intensive chemotherapy versus azacitidine with venetoclax. And it was a 1-to-1 randomization. It's a randomized phase 2 study, so there are only about 80 or so, 86 patients in each arm of the study, and done at 9 institutions. Now, there are some important things to realize about this study. Although it took patients, regardless of age, that were considered fit for intensive chemotherapy, the median age in the study was actually older, as I will show you. The second, and this is critically important, from the start, they excluded forms of AML that are potentially curable with intensive chemotherapy and consolidation without needing an allotransplant in first remission. So, of course, acute promyelocytic leukemia with the 1517 translocation, the core binding factor translocations, 821 and inversion 16, patients with an NPM1 mutation, as long as they were less than 60, they were excluded. Older patients don't do as well. And patient with a FLT3 internal tandem duplication or tyrosine kinase domain mutation, they were excluded because the RATIFY trial and the Quantum First study showed an improvement in survival with the addition of those FLT3 inhibitors, midostaurin and quizartinib. So very important to realize that these patients were excluded right off the bat. And they stratified based on the age of the patients, and they stratified based on what the doctor was going to give, what it was going to be standard 7 and 3 or the liposomal version of 7 and 3, which is the liposomal daunorubicin cytarabine CPX 351. And about 40 to 45% of patients got CPX 351. The others got standard 7 and 3. Now, an important thing to keep in mind about this study is that the doctors would be able to see what they were randomized, what their patient was randomized to. And I'm going to come back to that in a little bit for the discussion. The other thing is they required patients to get an early bone marrow biopsy at day 14, which is what we typically do with intensive chemotherapy. And if there was residual leukemia, give more intensive chemotherapy, or otherwise just wait for consolidation. However, in the azacitidine and venetoclax arm, lack of remission wasn't determined until later there. So I'm going to define for you the events that came under this primary endpoint. The events will be discussed on the slide that shows the event-free survival. And there are other secondary endpoints. But we can move on.
So what was the demographic of the patient population ultimately accrued?
So the median age, as I mentioned, was a little bit higher than 60 and getting close to the median age of the AML population, 64 or 65, including some people up to the age of 79 who the doctor felt could get intensive chemotherapy. Now, keep in mind, they could potentially get intensive chemotherapy, but what happens if your patient who is in their upper 70s is randomly assigned to get intensive chemotherapy? Are you going to accept that randomization, or are you going to end up excluding that patient from the study? And that's one reason why we have to see the consort diagram of what happened to patients after they were registered on the study. But you can see that about half of the patients were less than 65, the other 65 and older. The other thing to keep in mind here is the ELN risk stratification. Most of these patients, two-thirds to almost three-quarters, had adverse ELN 2022 risk, abnormal karyotypes, complex karyotypes, monosomy 5 and 7 to be some examples, and the spliceosome mutations, chromatin modifiers, P53 mutation, RUNX1. So we know who does poorly with intensive chemotherapy. Those are subsets of patients who do poorly with intensive chemo. However, Ravi, it's important to understand that except for P53, none of those are considered necessarily unfavorable for a response to aza-ven. So that's something we have to keep in mind when I get to the mutations below. About 10 to 15% had favorable risk, and I would imagine those were mostly patients with NPM1 mutated AML without a FLT3-ITD mutation who were older. Otherwise, the core binding factor leukemias were excluded, and there'd be very few CEBP alpha. Now, in this randomized phase 2 study, there was a clear imbalance in the number of patients with different mutations. If you look at patients that typically have a very favorable response to aza-ven, that's NPM1 and IDH2. If you add up those two columns, 35% of patients had NPM1 and IDH2, and it's 45% if you include IDH1. Look at the number for the intensive chemotherapy. Here, it was half that number. It was 15%, 16%, and if you include the IDH1, around 20%. So why is that important? This could have been just the luck of the draw from a randomized phase 2 study, but honestly, it makes me wonder if there was a little bit of what we call cherry picking. If the doctor's patient got assigned to intensive chemotherapy, but they knew that they had a regimen, a genotype that could respond favorably to aza-ven, maybe they would go with that and take, and take the patient off study, and vice versa. On the other hand, look at the P53. There were more patients in the intensive chemotherapy arm than in the aza-ven arm. And we know that intensive chemotherapy has a low response rate of about 30%, whereas aza-ven can have a 50-55% response rate even in P53. So a number of concerns about this, but I think the bottom line is keep in mind that most of these patients had adverse risk disease that went on the study.
Well, those are very astute observations, and thank you for taking us through the minutiae. That's what really matters. But given all the
It is.
issues that you have laid out, what were the official results of the study?
Well, as I said, the primary endpoint was event-free survival. Now, again, it's really important. Unfortunately, Ravi, the devil is in the details of clinical trials and when it comes to applying this to our patient population. So what were the events? The events were considered death, which makes sense. The patient moving on to hospice, that makes sense. If a patient had a response and relapsed, that was an event. But the other event that is typically an event-free survival is if the patient did not achieve a remission. Well, the investigators decided not to use that criteria because after intensive chemo, we expect them to have a remission after 1 or 2 cycles. And after aza-ven, we don't usually give up on that unless they don't have a remission after 4 cycles. And so instead, what they did is they said, okay, what we'll do instead is say if the doctor decided that their patient should be taken off their randomized random assignment and switched over to the other regimen, that was an event. Okay, now I'm going to come back to that. Clearly, the primary endpoint here was met. This is an incredibly positive study, the way it was designed. The adjusted hazard ratio for event-free survival with aza-ven remained significant in multivariate analyses, and you can see here that the median event-free survival was almost 15 months with aza-ven, and it was the event-free survival was only 6 months with intensive chemotherapy, and fewer patients had events in the aza-ven arm at 1 year. Now, again, here's the trouble with the study. Look at the shape of that the intensive chemotherapy curve. You'll notice that there is a very, very short plateau way up at the top, and then it drops precipitously almost 30 or 40 points within a month. Now, we don't have details of this, but as a clinician, I could tell you that in my opinion, what most likely happened was they got a day 14 marrow. The patient needed more treatment. The study required them to get more of the chemotherapy that just didn't work, right? 7 and 3 or CPX 351. And doctors did what they thought was best for their patient. They took them off study, and maybe they gave them another intensive regimen like high dose Ara-C or FLAG, because that does happen quite a bit. Or for this study, they probably switched them over to aza-ven because by now they know that the patient might have a genotype that is not going to respond to intensive chemotherapy. So yes, I think the way the study was designed, it was almost a foregone conclusion that there would be an incredible benefit to aza-ven if you're only looking at event-free survival the way you do here. But there are other things that we can look at that help lay out the importance of this data.
So I guess, does the response tell us something?
Yeah, let's look at their response, okay? So again, these were patients who had poor risk disease, okay? And if you look at the overall response rate, as well as the CR with incomplete blood count recovery or partial blood count recovery, those first 3 sets of bars, you will see that there was a higher response rate with aza-ven than with intensive chemotherapy. Again, with the caveat that some of these patients may have been taken off before they got a second cycle of intensive chemotherapy. So it kind of skews the results. And again, the consort diagram that we'll see in the publication will be very, very important here. But nevertheless, if just at face value, the CR rates, overall response rates were higher. The CR rate was numerically higher with aza-ven, but it did not meet statistical significance. On top of that, as I would have predicted, based on the genotypes that I saw previously, and the ability of a doctor to take their patient off of therapy for lack of response by day 14, you'll see that only 10% of patients had refractory disease with aza-ven, and it was 28% with intensive chemo. And again, that partly reflects how intensive chemo may not be very effective, especially in p53 mutated disease. However, it also reflects the fact that doctors were allowed to take their patients off of 7 and 3 as early as day 14 and switch them to something else, and they would be considered refractory to intensive chemo. Bottom line, a benefit, but again, because this is a randomized phase 2 study and doctors can make decisions along the way, we have to be careful in the interpretation of this data until we see the actual flow of patients through the whole paradigm clinical trial. There are additional efficacy outcomes that we can look at, however, and I think those will be shown on the next slide.
Yeah, got the slide up?
Yeah, so this is really important, okay? So if I have a young patient who's fit for intensive chemotherapy, who has intermediate or adverse risk disease, I'm going to try to get that patient to transplant in first remission. That is the standard of care, definitely for adverse risk, which was 2/3 to 75% of the patients. We are going to try to get them to a transplant. And in fact, I would bet, at least in my own practice, when I see a young patient who has clearly adverse risk disease P53 mutated, spliceosome and chromatin modifier mutations, multiple cytogenetic changes. I like getting that data back before I start treatment because that's a patient, even before Paradigm came out, that I would have thought about a less intensive therapy to start with. Um, because I know I have to get that patient to transplant. And you can see 52% of the patients got to transplant if they were initially randomly assigned to Aza-Ven, compared to 34. Actually, those might be actual numbers of patients, but clearly more patients got to transplant, which is what we would want to do. However, interestingly, even if they proceeded to transplant, there was no major difference in their survival. Furthermore, what's clear is that more patients received intensive chemotherapy after Aza-Ven compared to I'm sorry, more people received HMA-Ven after intensive chemotherapy. That makes sense to me. If you have persistent disease at day 14, or if you're not responding. But it was still almost half of the patients who were randomly assigned to Aza-Ven who ultimately got intensive chemotherapy. And again, we're not quite certain if this is after relapse. I'm assuming that this would be, during the course of their treatment, which means that although they started with Aza-Ven and maybe the doctor wanted to get them to transplant, maybe they didn't have a deep enough remission to get them to transplant. And so they needed to do something else. We just don't know until we see the details. And what's interesting about this comparison is if you're not careful, you might make the very wrong judgment here that maybe overall survival was similar in the two groups, because of the ability to salvage patients and the ability of transplant to overcome the disease biology. So overall survival really didn't differ between the two groups. Now, longer follow-up will be needed, but I'm concerned about that. I don't think we know anything more than we knew before the Paradigm study started, and that's going to include the tolerability of this regimen compared to intensive chemotherapy, which is shown in the next couple of slides.
Sure. We got the PROs and the healthcare utilization up here now.
Everything here is in favor of giving Aza-Ven first. The only thing that does not show a favoritism towards giving intensive Aza-Ven versus intensive chemotherapy is a patient-reported outcome on anxiety. And actually, you know what? That is the one piece of data that makes me think there might be something to these PROs. Because if the patients had less anxiety with one regimen or another, but they all have leukemia, I would have questioned that. All our patients are anxious, as they should be, with acute myeloid leukemia. But all of the other patient-reported outcomes, including depression and symptom burden, favored Aza-Ven. And very importantly, hospitalization in terms of the median number of days, the days that they were admitted in the first 6 months, the ICU stays, and actually what's not shown on this slide is induction mortality, all favored Aza-Ven. There was zero induction mortality with Aza-Ven, which was quite remarkable for this population. And so it's clearly something that is associated with less toxicity than intensive chemotherapy. And that we kind of knew, not from a randomized trial, but you kind of see it. If you then go on to look at other toxicities that are seen here, febrile neutropenia still occurred in similar numbers of patients in both groups, as you'd expect. There was actually similar numbers of patients who had platelet count decreases. Neutrophil count decreases occurred just as much with Aza-Ven as it did with intensive chemotherapy. And so when you look at those kind of toxicities, there's not real difference. The major thing that stands out here are the infectious complications, where there were fewer grade 4 lung infections and sepsis, or grade 3 and 4, I should say, with aza-ven compared to intensive chemotherapy. So all of these things favored aza-ven in terms of toxicity, such as, I should say, in terms of infection and what's not here, bleeding risk.
So it seems like if you look through the fine print, the top line data may be that the paradigm study isn't all that paradigm changing. How have you incorporated this data? Has it made any change to the way you practice?
It's made no change to the way I practice. And you know what? I think this is one of the difficulties with this study. Remember, it started several years ago. It had to start after we had aza-ven. There was already data coming out. For example, the data that was published by Dan Pollier and his colleagues looking at the use of aza-ven in patients who were fit for intensive chemotherapy. It was a phase 2 experience. It looked pretty good, and we all knew it. And so if we had a patient coming to us who we knew had a low chance of long-term survival or even a CR with intensive chemotherapy, and if we knew that their only chance for long-term survival was with a transplant, many of us were already erring on the side of giving aza-ven. And Ravi, clinicians do funny things. They like, what makes someone unfit for intensive chemo? Not just the Ferrara criteria, but if you have a patient like that and you want to sell to the third-party carrier getting venetoclax for your 50-year-old, well, all of a sudden diabetes and hypertension and all these other things that our patient populations have are comorbidities. And so you can make an argument that there are comorbidities that maybe will allow us to select for these younger patients. But be that as it may, even before Paradigm was started and completed, we were already doing this. We were already selecting for patients based on genotype and knowing that they would have to go to transplant for long-term survival, who might be better served by starting with aza-ven. And then, like in this study, if they didn't have a deep enough response to get to the transplant or relapse before the transplant, then you give them intensive chemo. So now we have this ability to sequence our therapies. So for me, it didn't change anything. Poor risk, adverse risk disease, I'm looking to start them with a less intensive therapy or an investigational therapy that may improve on outcomes. And we're doing that in MyeloMatch. So I'm hoping that the MyeloMatch protocol continues, where we are looking at intensive regimens like CPX 351 with venetoclax, 7 and 3 with venetoclax, aza-ven with venetoclax, to see if intensive chemo with venetoclax is better or worse than aza-ven, to get the patient into that deep remission, to get them onto a transplant. So I still think there are things that we could do here. My final point that I would like to really stress and end with is for the community oncologists. Remember that many patients were excluded from this study if they had NPM1 mutated disease and younger, if they had FLT3 mutation, so these patients were excluded, and if they had core binding factor 821 inversion 16 and APL, BCR-ABL. These were patients who were excluded from the study. And the benefit, I would say, is really going to be seen in those patients who have adverse risk disease. And so again, this is why my colleagues in North America, United States, and Canada, through the NCI, have developed the MyeloMatch Precision Medicine Initiative, because in 3 days, a patient's entire karyotype and genotype is given back to the doctor, and they could be assigned to an appropriate study. So we get this data back quickly. And I think that's what we really need to push this field forward in the initial treatment of AML, knowing what the patient's genotype is, and then making a rational clinical decision, or better yet, putting them on a clinical trial that will allow us to move the needle forward. Because at the end of the day, The paradigm trial, I agree with you, did not change the paradigm because the overall survival in this high-risk group of patients was still too poor to allow to continue.
Well, thank you for that deep dive into the data. Obviously, just an abstract being at a plenary session at a major meeting shouldn't make us think that things are as the authors sometimes conclude them to be. And I hope that the BioMatch study that you're leading is going to answer some of these unanswered questions. And hopefully, I can have you in due course of time tell us about the study as it reads out. Thank you very much.
That sounds great. I really enjoy doing it.
Thank you.